Hello, I'm Susan Acott. I'm the Chief Executive here in East Kent Hospitals Trust. I'm here today with three colleagues and we're going to have a bit of a discussion around life during COVID from a digital and a clinical perspective. So if I can get them to introduce themselves, starting with you, Mike.
So I'm Mike Bedford. I'm one of the Renal Consultants and also one of the clinical IT leads on our T3 project.
And I'm Andy Barker. I'm the IT Director of East Kent Hospitals.
And I'm Milan Thomas, Urological Surgeon, focusing mainly on cancers and also another T3 clinical lead.
So I wanted to really have a conversation around how digital transformation has and is impacting some of our clinical services, but we can't really start now without talking about what's happened during and at the start of COVID. So Andy, from your point of view, we had to move to a large-scale level of home working virtually overnight.
We did, and we didn't have much notice of that, of course. Typically, last year, we would have maybe up to 200 people able to, or actually working from outside the organisation, not all at home. Overnight pretty well went up to 600, and then within a few weeks we were up to 1,000 at any moment in time working remotely. That was quite challenging, but when you need to make these sorts of things happen, you do, and the team really pulled together to pull that off. So we got some really good feedback about that. However, the problem remained that we still needed equipment for people to have access to, and again we pulled some strings and got additional laptops in and that sort of thing. Pretty quickly we went up by about 2,000 laptops and computers. We also put 500 screens out that allowed outpatient clinics to be run with video and sound, and they have now been out there for a month or two. So all of these things were practical things that we were able to do very quickly. Of course, that really is only part of the picture because we needed to enable the clinicians to do their job. One element of that was to enable video outpatients to happen, so we quickly identified AccuRx as something that we made available within a couple of days of the lockdown.
Now, Mike, from your point of view, you've actually had to use AccuRx for your patients to keep them safe, but to keep your clinical oversight of them. Can you tell us how quickly that sort of adaptation had to occur and how you found it, and perhaps more importantly, how your patients have found it as well?
So yeah, very quickly, as Andy was saying, it was a change overnight. Straight away we had to question ourselves, why do we need to bring a patient into hospital? Why do we need to potentially put the patient at risk by coming into a clinical environment? And especially for our renal transplant patients, they're significantly, and the studies show, probably the highest risk of patient groups with COVID. So overnight we looked at how we could potentially facilitate having conversations with patients at home, but effectively. And we found that the video conferencing with AccuRx adds that extra dimension, and using that technology, a lot of patients have smartphones, especially the young ones, that they can easily facilitate that video, not only the conversation, but say a patient has just come back from transplant and has a wound that needs reviewing. They have an issue with it, you can quickly, even if you're on a telephone, you can quickly say, let's go to video conferencing. The beauty of the AccuRx and the system we had set up very quickly was it text message straight to a patient's phone, they click a link, directly you're in video conferencing. And it's just very slick, very quick, and removed a lot of the barriers to technology, so that we could look at wounds, we could look for our peritoneal dialysis patients, we could look at exit sites, we could look straight away, have that extra dimension. But on top of that, then we moved into, well, what do you need as a whole of a consultation? It's not just about the talking, it's not just about the visualization, it's what other parameters do you need? So blood pressure, so we looked at blood pressure monitoring, and Andy's working on a piece with us at the moment in how we can then bring that digitally into the patient record and bring that from the patient. Urine testing, we've been looking at a home urine testing that goes directly to the patient, that they, with their mobile phone, that can be monitored, and it can actually give a direct reading back to the clinician. And it's about how we facilitate this into a whole package of a clinical consultation, which remains safe but is efficient and for both the patient and the clinicians. And I think it was the key to the video conferencing was the simplicity, both for the clinical staff and also the patients, was the simplicity of the way it worked, in that it just broke down the barriers instantly.
Do you think your patients have adapted to it fairly easily? I mean, are they quite pleased not to have to come to hospital?
Most definitely. We had patients before clinic appointments ringing up saying, I'm not coming. And straight away then we had something else to offer. It wasn't okay, we'll cancel. It was, and for some patients we did cancel because it wasn't necessary, but especially for our at-risk population, we both didn't want to see them, but we had to see them, if you see what I mean. So a lot of them were very frightened and worried, which you can understand. And so instead of having to cancel an appointment, we had another avenue to take. Well, actually, we've got this, and that was utilised quite frequently.
And Milan, from your point of view, I guess you use those video conferencing facilities as well, but you've got a different issue in terms of how to keep the surgical interventions going during this difficult time.
Surgically, things are a little bit more apparent as to how you stratify which patients are appropriate for video consultations or telephone and which ones are more appropriate to a face-to-face. At the beginning it was really easy, everyone had to be a video consultation, there was not much thinking about it. But as we emerge from this pandemic, it's becoming clear that we want to reduce the risk to our patients. And there are certain patients who really benefit from a face-to-face consultation, and those are the ones who are listing for surgery and those who are giving new diagnoses to, particularly for cancers, which I deal with mainly. And it's been interesting also linking in with some of the local GPs, having webinars all on Microsoft Teams and all those other applications, is that everyone's having to think a lot harder because you're not sure whether the patient's understood what you've said to them. You're losing that face-to-face interaction, and someone described it as losing all your senses. If you were to shut your eyes and do a consultation, you're having to hear, smell, everything else a lot more intensely to make sure the patient understands. And so, although I am a real advocate for video consultations, we do need to be selective to make sure we get the right outcomes. And this COVID pandemic has been a real accelerator for all the good things that are happening, but it's also made us understand as to what we should and shouldn't be doing. And clearly with surgery, we know that we're changing the way we do things. Firstly, we're having to limit what we can operate on at the moment, and we're having to risk stratify the very high risk cancers for now, hopefully emerging out of this with more capacity to do other things. And that's been a real steep learning curve for us.
And what about alternative pathways for some patients at the moment?
So a prime example is prostate cancer. Prostate cancer is different to, say, kidney cancers, which I do, because they tend to be slow growing. And although they fit into the cancer pathways, we are obliged to treat them within 28 days or 31 days. Actually, even if you didn't treat them for a period of time, up to 6 months, sometimes 12 months, the outcome would be no different. But for the slightly higher risk prostate cancers, they have the option of radiotherapy. And in those cases, starting them on hormonal therapy earlier with a view to radiation, or sometimes even surgery, is an option, which we've tended to use more now in view of the COVID situation than we did previously. So there's a definite change in pathway.
From everything that you've all said, there is a great amount of learning and benefit and a sort of transformative approach. But clearly, it's been awful, awful as well. But it's going to stay around for a bit. So it feels like we're going to have to just refine these tools and make them work better for patients. What do you imagine are some of the next developments that you might try to pursue in the next few months, just to improve and refine the experience of the last 4 months?
Going back to video conferencing, I think what's been really interesting is in our department I've wanted to do a similar thing for a long time, and it's sometimes something like COVID that actually makes things happen. And actually the people that were a bit unsure about it are like, well, why haven't we been doing this for the last 5 years? Well, and it just takes something like COVID sometimes to push things. But I think now, as Milan was pointed out, I think it's now trying to work out how effectively to merge technologies. So we are going to have patients that will be on the telephone, we are going to have patients in person or patients on video conferencing, and how to smoothly integrate all those different technologies so that the patient doesn't think they're having a video conference but then is worried they don't have a smart device, or how we merge all those together to effectively run across mediums, which we're not used to doing. Instead of just, the norm has been you go to clinic, you see patients in person. Now it might be going to clinic, I'm seeing some on the telephone, some video call, and how we merge that to be efficient for both the clinicians and also for the patients, I think is going to be a challenge in the next coming months.
And Milan, for you, the sort of fundamental challenge is getting back to your previous levels of capacity, given the constraints of surgery. What are the options for you to be able to do that?
At the moment, we have a lot of theatres shut because we've kept the capacity for ITU. As time evolves, we will know how much capacity we need from an ITU perspective, which will determine how many theatres we can open. And once more theatres up and running, then the throughput starts to increase. And I know that the waiting lists are growing. There's not many other options for patients at the moment because we've had to use other facilities as well. That's a waiting game, and that's out of our hands as surgeons. We are reliant on operationally things changing. But I certainly think that any adverse situation, we learn to adapt, and certainly we probably are more selective than we used to be, and that has created a change in the way we do things. So perhaps patients are not presenting as much as they used to, particularly for the less urgent things. There used to be a case that patients had incidental things picked up and were referred in, and that's happening a lot less at the moment. So we may now treat people who actually need surgery more so than they did before.
Yes, I
but
understand that.
On the flip side, there is also a lot of patients who do need surgery, but they don't meet the criteria to have it urgently, who could come to harm. And so we've got to play this balancing act, which is not an easy game to play.
One of the things I wanted to ask you, so you're all involved in the T3 project. At the moment, I think what COVID has also shown is to balance risk, you need information, and you need information to be shared through multidisciplinary teams quite frequently. Andy, from your point of view, have you thought around how the T3 programme comes into play in the same way, or does it need to be adjusted with the considerations around COVID?
I think what we certainly know is that whilst at the beginning of the COVID crisis, as Mike said, it sort of pushed us into change, actually at that time we were able to accept a relatively low level of information, and we may do in a way that won't be acceptable quite soon. And so in order to provide that appropriate level of information, we need things like T3 to come online. And I don't think actually we have to change the original plans. I think where we were heading, which is an electronic patient record, is still the right thing to do. There are some things that T3 was not planning to do that maybe we have to now think about a solution for. One that's close to my heart is how do we get patients to give us electronic feedback, self-assessments online, that sort of thing, which is what we're working on at the moment, and I think that will be a bit of a game changer as well. That will come in within the next couple of weeks.
One thing that's quite close to my heart that you've slightly mentioned or linked into, Andy, is whether through COVID, but also then through the T3, you can get patients to be more interested in understanding of their own condition, and you can engage with them better around their own condition.
Definitely, I think we're finding a lot more now. Patients have smart devices, smart watches, they're gathering a lot of their information, and I think that's a real opportunity for two things. One, to engage patients more and encourage them to do that, but also to facilitate their care. If you think about a consultation, so I see a patient in clinic, they have a blood pressure done before they walk in the door. That's one blood pressure. They've probably had 50 done by their watch in the last few days. Yet we're balancing it on one, and we need to see how T3 can bring that wealth of data that is developing into the clinical record and into clinical management and clinical care.
Yeah, absolutely. And from your point of view, Milan, what are you looking forward to with the T3, perhaps through the lens of COVID?
As you know, I am an advocate of this, and I use this in a previous hospital. As things are progressing, it's coming online, and we'll hopefully have the Shadow go live happening soon, and everyone's going to have a chance to play with it. Mike's already said it. This is about accountability, reliability, and also having a system that will mean that we won't have the old problems of lack of notes available, because it's always there, it's always up to date. Reliability, so you won't have legibility issues. Everyone's going to have to write it, and it's signed with the clinician's name or the healthcare provider. And eventually, when we move to electronic prescribing, we will have accountability, because you will know who's written that prescription. And if there's a problem, you can go straight to that clinician rather than having to guess what a squiggle refers to. So I'm really looking forward to that. I think it's going to be a real turning point for the management of our patients.
I think one more thing I'd say on that, I think COVID has definitely shown us, if you think back to in the A&E in the COVID environments, and paper couldn't be moved around, you couldn't take it out of that area. Electronic record solves that instantly, and I think it really does show how much we need T3.
Yeah, that's a good point actually. Records have become a source of transmission, haven't they?
Definitely.
So if they're electronic, then that's one less source of transmission, isn't it? Yeah, good point. But what are some of the just sort of brief memories or thoughts that you would take with you? If we were to have this COVID diary and we're collecting this and we're going to look back at it in 5 years' time, what would you want to remember, Mike?
For me, and working on the ward during the time was just the teamwork. It was just amazing. Barriers just got broken down. Everyone worked together. It was one goal. And I say it's the same with the use of technology. The barriers just disappeared, and it was a can-do. And it's why can't we be doing this? And it was really positive. And I think if we had that in the whole of the NHS all the time, it'd be amazing.
Yeah, well, we need to try and keep that at the moment. What about you, Andy?
Well, Mike said it really. I mean, the ability to make change happen quickly was really phenomenal. If I say something different, it would probably be around the fact that it is possible to maintain a team culture electronically and virtually.
Yeah.
And that, I don't think I would have predicted that pre-COVID.
Yes, it's been quite impressive actually how much togetherness there's been, even if it's virtual togetherness. Yeah. Milan, what about you? In 5 years' time, what are you going to look back and want to retain and remember?
Well, I would reflect personally that it has been an extreme challenge to do things completely differently. But to tie it in with what we're talking about is how rapidly change took place. And that never happens in the NHS. Overnight, we went from everyone being in a room to everyone speaking through screens. That's never happened before. And everyone talking to their patients via telephone and video consultation, not seeing patients and listing them for surgery. That's unheard of. And, in some circumstances that might remain. And that acceleration of change is, it's a testament to how well we adapt as clinicians and individuals and all the staff in the hospitals, and we should learn from that.
Well said. Well, thank you very much for your time, gentlemen. Very, very interesting, and thank you for what you've been doing for the last few months as well.
Thank you very much.
Thank you.